is Dr. Bill Hayes, and I want to do a video series that may be a little unique. I'm an orthopedic surgeon, but I'm also going to be a patient. And I wanted to start, this is a pre-op segment we're going to do, talking about my journey with an arthritic right knee, going from all the non-operative treatments I did that were successful for a long time, and now I'm at the point where they're not quite so successful, and I made the decision to undergo a surgery in a couple of weeks. So this series, this is part one. It's going to talk about what arthritis is, what treatments worked in the past, and maybe why they don't work so much now. What can be helpful in a non-operative state, because many things we do are very successful non-operatively. This has been a process of maybe 10-year journey of getting worse and worse with my knee, and now at age 60, I'm going to undergo surgery in a couple of weeks. So the first thing I want to talk to you about is, well, what is arthritis, okay? So, and I know we have segments, Dr. Flowers and Dr. Chin have both talked about that. So just briefly, the ends of the bones of all our joints have cartilage, and cartilage looks like a cue ball. When we put a camera in the knee of a normal looking knee, this looks just like a cue ball, and that would be called grade 0. When we're inside a knee, orthopedic surgeons would communicate to each other, it's a grade 0. A grade 4 is when that cartilage is no more, and it could be in one little spot or it could be global throughout that, but somewhere between there, a 0 and a 4, there's different grades. It's grade 1, 2, and 3, and it could be just a little bit of change all the way through deep fissuring and chunks of cartilage taken out. But what that leads to in a radiograph are changes that we can see. So I wanted to show you a normal appearing radiograph here. And what we look at is we can't see the soft tissues, but we can infer that the cartilage and the meniscus cushions have maintained their structural size just based on how that spacing looks. So the spacing is based on the fact that the cartilage doesn't show up on x-ray. There's no calcification there. So contrast that one, which I wish I had that one for my knee. This is my knee. Okay, so this is my right knee, and when you look at it critically, you can see the lateral side looks okay, and on my kneecap view looks okay, but you can see that not only is there no space there, but you can see how white it is right there compared to a normal x-ray. That whiteness there is called sclerosis, and that just means that bone has been under a lot of duress because there's no more padding there. And that's a result of, I've had some significant knee injuries snow skiing, and I knew that going in, and I've had a couple of knee surgeries to that over the past 20 years of my life. But when we get to this stage, that doesn't mean you need to race to a surgery. I've probably had this, now it's getting worse over the past 2 to 3 years, but I've had something like this over the years. And the non-operative things that were successful initially, I tried really hard, and I always encourage patients the same way, is the things that I can control, my weight. So I'm really trying hard to lose weight during this time. And if I had maybe to do it again 10 years ago, I would have focused more on that. But keeping your weight down can be very helpful. It takes the load off this poor knee. Other things you can do, stay strong. So your quadricep, if your quadricep is strong, that's your shock absorber. It's going to help. Exercise that's not hard on your knee, like a stationary bike or swimming, those can be very helpful as well. And that's a great initial treatment. Some people have had success with modifications of their diet. I've had some patients that went on an anti-inflammatory diet, and man, it really helped them. I'm all for those kind of things. Some people are successful with 8-hour Tylenol or an occasional anti-inflammatory agent like Aleve. No problem trying that, right? We're trying to keep you active and doing what you want to do. And that's what I did initially, and it worked. And then I went on to the next step was it wasn't working so well. So I had a steroid injection. One of my colleagues in this group doing a steroid injection. What the good news about a steroid is it works usually pretty well initially. The bad news is we don't do them frequently because they can be harmful in bigger doses. So we try to keep our doses small. I also did the viscosupplementation. Many of you have probably had that at this office or others. that's a lubricant we can inject in the knee, and that can be helpful as well. And then finally, those things stopped working as effectively as they used to, and I went on to PRP, and Dr. Chin has a video that is really good talking about what a PRP is. It's platelet-rich plasma coming from your own blood. That worked it would give me a year of relief for many times. I think I had it 4 times. This last time, it just wasn't as effective. And the final thing we can do mechanically without surgery is what we have a brace called an unloader brace, and you can see how I'm becoming a cowboy. I'm becoming more bow-legged. We can put a brace on this knee, and I have one where it makes the weight go through the outside of the knee. And that can be very helpful if your pain is only, say, when I walk the dog or when I play tennis and I don't really hurt at work or at home. It's just when I try to do an increased activity. It's a great thing to try, right? So those were all tried and used for many, many years. And now at age 60, and I wanted to share with you, and this is what I share with patients a lot. This is the first summer when we went on vacation, my wife and I were on vacation. It's the first time I said to her, I didn't ask her if she wanted to go on a walk or a hike. And that's profound. And she brought that to my attention. She's been with me 35 years. She said, "Can I be real with you?" And I said, "Yes." And she talked to me about that my brain just would say, "Let's go on a bike ride," or "Let's go to a movie," or "Let's just sit around and talk." That's just not me. And she knew that. And what I'm now doing, and that really hit me because our brains, and a lot of patients talking to you guys, start just adapting to the pain and just don't do the things that don't hurt anymore, right? So when I ask patients, I don't say, "Are you in end stage pain?" And that's how I was taught in residency. It's not that. Have you stopped doing the things that you love to do? Do you love to go play golf? Do you love to play pickleball? Can you not do those things now? That's just as important in my mind as end stage pain. I mean, end stage pain will grab our attention, but if you can't do the things that you love to do, come on, that's why we're here. We want to get you mobile again. So that was the decision maker for me. In that I looked at pictures of myself a year ago. We were hiking. I was playing pickleball. I went on a turkey trot. I didn't turkey trot. I walked, but I could do it. Not this year. And that's a different change. And then my x-rays have slowly progressed too. So over time, that narrowing has gotten worse. And that's just normal aging. And we see that as adults when we look at menus. I can't read the menu and I need to get a different pair of glasses, right? And that just comes, we just do that and adapt to it. Well, I believe we do the same thing with our knees and our hips. We just adapt to the pain and then just say, "Oh, I just don't," and maybe subconsciously, "I'm not going to do that anymore." So that was the instigator for that. And the thing also I share with patients is I have a lot of my friends that are a little bit older than me. They're neighbors, friends, they go to church with me, and I've been talking to them about this, and they finally decide to do a replacement. And I can't tell you how many people say, "I wish I would have done that 5 years ago or 10 years ago." And I'm 60, and I want to be able to go out and play golf or go on hikes or walk my dog without the pain I'm having now. So I want to share with you what a replacement is too, a little bit. And Dr. Flowers talks about this, but the replacements we do are all done with the robot assist. And this is a picture of a partial replacement. You can see, and this is what my docs are saying I'm probably going to have. They're also counseling me that I may have a full, but on the partial, the reason I'm a candidate, at least it looks like, I have isolated wear, and it's profound, but over here it looks okay. So if that's the case intraoperatively, they only need to replace a third of my knee. This part is where the kneecap glides over, and sometimes that's arthritic. In my instance, it's not. So I'm looking at a procedure like this. In both instances, it's the same approach, the same surgical incision, and in both instances, they use the robot. Now, what the robot does, and I'm learning this because this is not my area of expertise, but what I'm scheduled to do this in a couple of weeks. I'm going to have a CAT scan done, And the CAT scan takes specific markers and points in my knee, and that gets programmed into the robot. And the robot is going to be the thing that makes the cut. And that's the precision of this cut is what renders the wear characteristics so much better than when I was in training. So the robot's going to take the information from the CAT scan. My surgeon is going to hold on to the saw to make the cut, but the robot is guiding his hand. And I love that. So it's going to be a very precise cut. So right now I'm about 2 weeks out from the surgery. No, 3 weeks out from the surgery. I'm going to have the CAT scan. I have a preoperative clearance from my doctor. And then in the upcoming videos, we're going to do some at the time of surgery, and maybe some pictures in the operating room for you guys. And then the next set will be during physical therapy in the post-op period. So thank you very much and stay tuned.